Is there possibly some middle ground where, if it's below a certain dollar threshold, they have to find some offsets. If it's within some, intermediate range, I mean, you mentioned earlier copays and deductibles. I mean, when Medicare was created, the Medicare Part B premium was supposed to cover 50% of the cost. And over time, that was eroded. And, the standard premium is 25% of the cost, although it's means tested. So if you're a high income individual, you could pay up to 85%. But still, there's no one on Medicare who's paying 100% of the cost. And
Right.
even Part A, which is supposed to be funded with a payroll tax, has a shortfall of about, over the present value over 30 years, 75 years is like about 30%. So you could argue that, if you were to combine Part A and Part B, establish a uniform copay, premium, and deductible, that there's significant room for the beneficiaries to contribute a little more toward the cost of the program. And so if you have this intermediate range, you could allow CMS to adjust premiums and copays like normal health insurance does or employers do with their own employee health benefit plans. But if it exceeded some upper limit, you'd have to tell Congress, okay, you've got to find source resources outside the system.
Yeah. Well, I mean, I think that's exactly the idea of having a threshold above which it requires explicit congressional authorization is exactly how I think we would phase this in. So you could say any new procedure that costs more than $1 billion a year, you can't do it through executive action. You need legislation. And that I think with offsets, uh, that I think is just intuitively very hard to argue against. How could you possibly have a $10 billion expansion of the program over 10 years and not have Congress have a say in that? I think that makes a lot of sense. And that obviously just creating that requirement itself generates a $10 billion pay for that Congress might quite like. It might quite like the ability to say, oh, we lowered this threshold, the sky didn't fall. We created a process for assessing the value of new procedures, and we generated pay-fors by creating this process. Maybe we should then lower it from $1 billion to $500 million or $200 million. And and we would find out over time what is the level of granularity at which that process works and at what level does it no longer work. So I think that's a real possibility, and that's certainly how I would look to introduce this. The other thing here to bear in mind is that most Medicare beneficiaries are now in Medicare Advantage, which is a capitated um, arrangement where Medicare, federal government pays a private insurer a lump sum to take care of a beneficiary based on their health risks. And that's the amount of money that that insurer has to basically take care of the beneficiary. Insurers are allowed to add new services and procedures before mandated to do so by CMS, the federal government. And so that really going forward can be the primary way of expanding the program in a routine way. If you have a cost-effective new procedure that actually saves money, private insurers are going to be adding that to their benefits without any intervention by the government whatsoever. If there are some that are attractive new services but cost a little bit, these insurers might say, well, it's worth taking money out of an existing service and giving it to this new service, maybe increasing the cost sharing for an existing service. And the Medicare Advantage plans actually really do have the flexibility and authority under current law to do what I think you're suggesting the CMS would do. And it's actually probably better that the insurers in Medicare Advantage do that than CMS, which doesn't have the authority to alter cost sharing or alter premiums. Insurers already have that authority, and so relying on Medicare Advantage really to handle the small ticket items, the small cost improvements of benefits, the cost effective improvements of benefits. Medicare Advantage plans can do that unilaterally under current law, and you would only need the intervention by Congress to really tackle the major, multi-billion dollar Alzheimer's drugs that are potentially on the horizon.